Hi, everybody. It's Rajan Roos, CEO and founder of the San Diego Pain Summit. And joining me for this portion of Clinical Pain Mastery Online is Dr. Jonathan Fass. So thank you so much, Dr. Fass, for joining us. And a little bit about him. He's the former physical therapist and sports manager of His Royal Highness Prince Alawaleed bin Talal, billionaire investor, philanthropist, and humanitarian. Just rolling over. He's a graduate of New York's physical therapy program and attended his orthopedic physical therapy residency at the University of Delaware. Jonathan is a certified strength and conditioning specialist through the National Strength and Conditioning Association, a certified health and fitness specialist through the American College of Sports Medicine, and he has guest lectured at Rutgers University and Drexel, as well as APTA's Combined Sections meeting, and has been featured in several Men's Health magazine articles. And currently, he's a clinical specialist focusing on chronic pain conditions at XL Physical Therapy in Philadelphia, and is also a fellow in training in orthopedic manual physical therapy with the Next Gen Institute. So welcome, Jonathan. Thank you so much for joining us. And I have a question. I read this really interesting paper and I mentioned it to you, and you were like, yeah, that's, but Pain and Movement Reasoning Model by Lester Jones. I thought that was really interesting, and I'd like to hear some of your thoughts about that.
Absolutely, and thank you for having me. It's actually one of my go-to papers, and I think there are a number of papers that are similar, and I think that the question that basically all of us, any of us that kind of come across this sort of research, understand that there's a new way of thinking, really a paradigm shift in the clinical rehabilitation of patients with chronic conditions, pain conditions, is like, well, how do I do it, right? So there's a lot of information, there's tons of research, there's lots of journals, and then you get out to the clinic and you go, so am I supposed to talk to people for 50 minutes? Like, what am I supposed to do?
So how does that come into the practice of what you're doing?
Exactly. And do I have to forget everything that I've learned beforehand? And so the Pain and the Reasoning Model, to me, was a really nice paper that put things together, because I know that I had those same questions too. I know for a while I was practicing and it is like, oh, I don't think biomechanics matter at all, and these sort of things. And they do, but how do you kind of put all that together? So what the Pain in that paper does, I think that it does very well, is it lays out the concept of like, look, these aren't separate things. Not only are they interactive, but you should be thinking at all times of all of these things. And by that, I mean local factors, regional factors, and central factors. And so what that paper does is it highlights each of these areas and put your focus in assessment and treatment in where do I think, where is an issue showing itself? Is there a local factor, a tissue deformation or inflammatory response? No, you don't need nociception to experience pain. It's not sufficient. But to my knowledge, there is no evidence that you can have no peripheral sensation, right? There is something value about peripheral tissue. There probably should be, because it kind of doesn't make sense to just have a brain in a jar in pain. That doesn't really vibe, with what we know about reality. So you have these central factors. What is the tissue of interest? What is the tissues? That's usually what we're pretty good at anyway, right? That's what most of our background training came from, is which muscle and which is weak and what's doing what. Mm-hmm. Then we go into these regional factors. That's not only the concept of a regional interdependence, this association, say if I have knee pain, I probably need to look at the hip or perhaps the foot and ankle, this idea that the hip bone is connected to the knee bone and so on and so forth. But you also have regional factors in terms of a pathoneurodynamic influence. Is there a peripheral nerve conditions that are influencing local sensitivity, or the guarding behaviors of the maladaptive guarding that we might find, as well as the idea of a convergence, the convergence of neural signature. So that is like the example of, I have left shoulder and jaw pain, but we recognize that as being a heart condition, and yet the heart isn't in the jaw or the shoulder, but that is a convergence of excitation. And then finally, of course, the central factors, this is the pain science stuff, but really understanding how that can affect all of these issues. It can turn the volume up, it can turn the volume down. And then what, of course, are the psychosocial influences as well. And when you look at it as these things, and of course, not every case has every one of these things in relevant terms. I don't need to treat someone's psychosocial presentation if they're calm, cool, and collected and not concerned about their rehabilitation or their recovery or things of that nature. It's still there. I still want to make sure it doesn't become an issue, but it may not be something that I need to address at that moment. But by thinking about all of these things, I think that it allows you to take that step back and look at more of the larger picture and start to understand where, even though it feels like, wow, all this new and exciting stuff, maybe I should focus here, we need to not forget what we've learned, but to be able to integrate into everything that we do. And that I think that paper does very well.
Yeah, that's what I was thinking, just listening to you talk about it, is clinicians are already learning that information when they come out of school. So taking this step back and doing the rounded view doesn't mean that everything you learn, it negates all of that. Those are still important things to consider. Mm-hmm.
Right, exactly. And I train, my students that way, and other clinicians as well, because they come in, and a lot of times I think that we need to be good in communication and not negating what they understand, and not negating necessarily the things that they do, just trying to put that into a larger picture. I use that example of like the paradigm shift, which is a concept of a philosopher named Kuhn that looked at scientific revolution basically and how things progress over time. And instead of thinking of it as, this one lone genius and then everything changes, it really seems to be this kind of ordinary scientific discovery until there's enough problems with the current paradigm or the current thought that it really does necessitate a change in the way that we think. And so the obvious one is something like Einstein and how it came along and revolutionized the understanding of gravity. But gravity existed before Einstein. So and we still use the methods of calculus and trying, for most things. And it's only at this really specific time and specific relativity and things like that where we kind of change the thought process. But we don't throw out what came before. We just understand that it wasn't quite right. And if we just shift, all of a sudden it opens us up into entirely new understanding and fields. And that I think is rehab too. There were a lot of things that people do very well. And there are a lot of techniques or approaches that people use that work very well. Some of the reasons that they work may not be for the reasons that we were, taught originally, but it doesn't mean you throw the baby out with the bathwater. And that is true of mechanics. And especially in that concept of regional and local, it's pretty solid. That understanding of how things work is pretty solid. What's not so solid is that, well, this is why you hurt. That part, maybe not so much. And if we understand that and take that step back, it opens us up to new opportunity without losing the original stuff that we are pretty good at. If someone comes in with an ankle sprain, we're probably pretty good at dealing with an ankle sprain, and we shouldn't forget how we used to do that. We just may want to change a few things here and there to be more consistent with literature and an overall understanding. Because you don't want to say one thing and then do another. That's confusing. That leads to poor outcomes. It's all the bad stuff you don't want.
Yeah, like harking back to when you said people like to say don't throw the baby out with the bathwater. And something I often hear a lot is, so if what I'm doing isn't going to change, why do I need to bother learning about this shift? Because I'm still going to keep doing the same thing anyway. So what's the benefit of course, keep doing what you're doing, but what's the benefit of stepping around that shift and stepping back and looking at the bigger picture?
I think what happens is it makes you, so if you think about clinically, what are we trying to do for our patients? Very often we're trying to make them more robust. We're trying to make them more capable of doing more things and moving in more and different ways. That's kind of what we should be looking to ourselves to do as well. So it's not so much about the patients you're already good with, although there may be the argument you could always improve. But if you're solid, hey, I feel really confident in this area, that's great. But there's always that patient that didn't get better, didn't improve, may have even gotten worse. And, in the past, those were things we used to blame the patient for. Oh, they must be faking. They must not be doing their exercise. They must not whatever. And in truth, there's probably a lot of opportunity for those patients to improve and to get better. And I think many of us have probably had the experience of receiving patients after someone else's care, where it was not a good outcome, where they were told one thing that really isn't accurate. Now they're looking in a direction where you're saying you don't need to go the surgical option or this option or that option. It's those patients that really gain the benefit, and not just for your interaction with them, but for their future as well. So if I'm not going to change how I approach the problem, that may be the case, but might I change my education of why I'm approaching that problem? How can I do exactly, what is, the hot topic these days of that therapeutic alliance, and really having a patient or a client for life, someone that you are their go-to. And that is a privilege, and you need to earn that privilege. And I think that you do so in making them part of that recovery cycle, that specific plan of care. I don't discharge a patient, I discharge a plan of care. And when they trust me and they understand that I'm going to be open with them, honest with them, and by knowing more and being able, even if the manual thing I do is the same, or even if the exercise I do is the same, all of that counts, and all of that can lead to better outcomes and lasting outcomes, so that the next time that they hurt their shoulder and you saw them for a knee, hey, the knee's doing great, and I want you to work on my shoulder this time. So I think that you can look at the basics of what you do and decide, no, I like it that way, but to have a better understanding in that bigger picture and bring more things in that you wouldn't have done before.
Yeah, so it sounds like not only does it help the patient just in general, but it also improves your quality of education and skill and that sort of thing. So I wonder what what's preventing clinicians from looking at it that way, as opposed to just not being interested in, like, how can we you know lift that veil, or however, so that they can see, hey, it is an addition to my education, and it does help the patient. There seems to be something blocking that. It's not very porous. We can't get through. So what are your thoughts about that?
Yeah, and part of that, of course, is what I spoke in 2017 at the summit about too. But it's really about making it safe to venture out of your comfort zone, and about not aggressively attacking someone's practice, but rather trying to lead them through curiosity, through the development of interest in the things that you're doing. And that's the same with patients too. I mean, I think that as a personal example, I used to do the whole pain neuroscience education. I'm going to sit you down and I'm going to, teach you about what's going on. And I still do it, but now I try to think of the movie Inception. I want them to think that they're in control of the dream, but really I'm pulling the strings there. When they come in and they say,
Until the
what's
ending,
going on?
right?
What's that?
Until the ending.
That's right, until the ending. So they come in, I got the imaging, it's bone on bone. I don't take that away from them. I meet them where they're at and say, okay, it's bone on there. But here's something really interesting. There was a study, they looked at what was sensitive in the knee. Guess what the least sensitive area was? It was the surface of the bone. So, and we can do better, because if it's bone on bone and we get you moving, then that will decrease that space. And by the way, the nervous system is causing that muscle tension. So if we I don't even mention the brain anymore, because then they just walk away thinking it's in their head. So, talk about the nervous system and why you would feel pain and what the defensive mechanism and these sort of things. But I let them keep that bone on bone, because I need to build trust over time. I can't just bash them over the head with something. And so it becomes this long game. And I think the same thing operates with clinicians. It's on the one hand, I think there's a great way of doing it is that, money talks and BS walks. So if you're in your clinic and you're providing excellence in care, other people take notice of that. And they start to go, what are they doing? And that's something right there. That's that curiosity factor. That's why do they keep getting people better? Why does it seem like, when they might cover your patients and that patient is always getting better. And then their patients aren't getting better all the time. Things of that nature starts to get them curious about what's happening. The same thing with any referral source that you may receive. That can be friends and family. Hey, my therapist did a great job and your back is hurting, you should go see them. But of course, also physicians and other people in the healthcare world. Are you getting their patients better faster? Are your notes excellent? Are you spotting things they didn't? Are you doing things that really makes people take notice? Ultimately, that's what's going to happen. Ultimately, it's going to be weeded out in terms of who is effective and who isn't.
Because they'll be curious, and then they'll start to want to know why.
Exactly. And that's where you have the opportunity. But if you come in and you just say, well, you're doing that wrong, or hey, I have a better way, even when you're trying to be helpful, if I'm having a rough day or I'm a little insecure about the fact that this patient isn't getting better, then someone wants to walk in, it's a difference from when we're students and we're kind of like forced into that learning versus now where we can't really, we're clinicians, we're licensed, we're whatever. Maybe I don't want to hear, even if it's right. Maybe I just don't want to hear that. So I think playing that long game and saying, you know what, I will lead by doing and take the opportunities when I see them to add a little interest, get a little curiosity, or just establish myself as, hey, no, I'm not trying to harm you or your practice. You're excellent in your own right, but maybe we can kind of bring things along. And there's still, there are clinicians I interact with, they do something that maybe I wouldn't do, but you know what? That's okay. Mm-hmm. We don't win every battle, but maybe if we, take the longer view, we'll be all right.
Yeah, and just for anyone who's listening, Dr. Fass's 2017 presentation of the summit is actually free to listen to if you just go to SanDiegoPainSummit.com/membership and scroll down. I have yours is one of the presentations that's just free because everybody should watch it about communication. But what was interesting, Jonathan, what you said, so there's 2 points I want to comment on. And one is one of the patients who spoke on this clinical pain mastery discussion group, she was talking about, so she was a pain patient for many decades, and that actually inspired her to become a clinician because she was treated so badly and her care, it took so long. And she was saying how when she first went in for her diagnosis and the therapist said, your ligaments, pelvic ligaments are torn. It's out of whack. If we don't strengthen it and get it back to bowl in shape in your core and all this. But it was said, but when she went for that first appointment, that was the authority. So she believed that story because that was the first story she heard, that was authority. So in all the other clinicians she went to over the years, some of them would try and talk, create a therapeutic alliance and all this stuff and talk to her about pain. But because her first introduction was with something completely different, she just immediately wrote all that off because it didn't match the story that she was prepared to come in with. Right. And secondly, I just wanted to bring up, and I mentioned this before in another discussion, that Gregory Lehman gave a talk recently, and somebody asked him in the audience, well, what if they come to you and they have bone on bone? How do you talk to them about that? And he said, I just say, okay, and so here's something else we can look at. Right. Kind of pretty much like what you said, right? You can't talk them out of that story.
I think what you try to do in that circumstance, and that happens all the time, they've been told by an authority, they take that authority, it makes sense. A lot of times what I do first is I try my best, and the more I practice, the more I've learned to not make any assumptions. Hey, tell me your story. Okay, I have this, and that, it's bone on bone. They said because of this, because of that. Does that make sense to you? When they explain that, did that make sense? Yeah, that makes sense. Okay, great. And I leave it there. But I may keep that in my mind because if I can show them, the most important thing to that patient is, what can you do for me? I came in with a problem. I came in with pain. I can't get up out of a chair. I can't do whatever. That goes into things like psychomotor training and giving relevance to the movement that you're prescribing. If I give you a bunch of exercises or just a bunch of exercises, and then I go home and it still hurts to get out of the chair. So who cares about my knee extensions? I don't even know why I'm doing them. So a lot of times the exercises that I would prescribe for a home therapy program, they're limited, they're short, one or two things, and most importantly, that they have relevance to their issue. And if I can be greedy enough, I'll take care of some of those things right on eval, meaning I can't get out of a chair. Great, let's see what we can do. Because when they say that, what they're saying is the way that I am accustomed to getting out of a chair, I can no longer do so without pain. It doesn't mean I can't get out of a chair without pain or significantly less pain. So now I'm going to play. And I let them decide what it is. So I don't say, well, put your feet here and do that and that. Great, isn't that better? We become, we're a team and they have to help me. I'm a coach to them. So we're going to start, make the legs wider. Does that feel better, worse, or the same? Bring them in tighter. Lean forward, lean back, do this, that, and another. And eventually you come across something where they go, ooh, that didn't hurt. That's their exercise. That's their tool. I ask them to name the weight distribution, or were you leaning forward 50-50, 70% to 30%, whatever it is, and that's their tool. Now it's not an exercise, it's a way of engineering their problem. So they can come with any type of information and otherwise, but I've shown them how they can move differently and how that's going to affect them. And if I feel kind of like, maybe I've won them over, I can say, now let me ask you, if it's bone on bone, how is that possible? And they'll realize maybe it's not, and I'll say exactly. So don't worry about what's in there, because that doesn't mean that's your future and that's your fate. We can change it through movement. You've already done that. You're going to continue to do that, and we're going to feel better. And so it doesn't matter what that other, and I'll even explain that to them that, look, if it's a physician, bone on bone or whatever, that their expertise is microbiology. You're not coming to me to ask what type of approach to the surgery you should have or what injection you should receive. But we are looking at macrobiology. How do you move, and how is that movement consequential to how you feel? So in the same way that you shouldn't be asking me what surgery you should have, we're going to be able to be authorities over how you move in a way that other people haven't been trained. So I don't want to throw them under the bus, because they have faith in that other provider, and there's no benefit to doing that. But what you do want to do is let them understand that there's a different way of handling this situation, and we'll be able to do that.
So it almost sounds like a cross between like what my strength and conditioning coach does with lifting weights and everything, about changing your body's position to see how it feels. And then Feldenkrais, which I've had a couple years of training, which is noticing how you move. So really it's about getting them to perform that activity, but in a new way.
Right.
And it seems like once you get that win, so once you've done that and they're like, whoa, I stood up and I don't really have any pain. Now the therapeutic alliance has been formed. Right. Now you have that opening.
Mm-hmm.
Like,
that's exactly right. And it's funny that you mentioned Feldenkrais and Alexander method. I've had people over the years tell me that, and I'm like, yeah, I never read either of them. And it's not bragging. It makes sense to me. And those were obviously very gifted clinical approaches, clinicians. But that's
movement.
Exactly
it's just movement. It doesn't matter how you label it. It's just
exactly.
movement.
It's just
noticing the movement. That's it.
Exactly right. And so you just coach them, like you said, you coach them in the direction that you think will probably work, but I'll make no assumptions. And I've definitely had people, I'm sure they're going to move this way. That'll make them feel better. And it's the opposite. But it still looks like, I must know what I'm doing, because it doesn't hurt anymore. And I let them lead me that direction. And I just make sure that it's, I can kind of adjust as necessary. But when they arrive at that conclusion, that has relevance. When I tell them what to do, okay. And then they come back and they didn't do their exercise, and then you yell at them, and then, it's the same kind of thing. But when they do it, whoa, that's different. And now they understand their own power, because ultimately you don't want them reliant on you. They should understand that they have control. And what is pain if not robbing of control, of individual choice and ability? So you want to show them how they still have that, and that's not taken from them. But we just may have to look at the problem in a different way. So that's what we do.
That actually reminds me, I think it was Dale Carnegie's How to Win Friends and Influence People. I can't remember because it's been decades since I've read that book. But I think he talks about it, or somebody has talked about, if you want somebody to do something, you make them believe that they came up with the idea for it. Yeah. But in a genuine way, not in a manipulative way, but you let them come up with the idea, and then they're more likely to do it because they came up with the idea. That it reminds me of that.
That's exactly what it is. Yeah, that's exactly what it is. If you know, once you have that trust bond, you can be a little bit more loosey-goosey with it, and try it this way, whatever. But there's absolutely that initial assessment and diagnosis, that first, 1, 2, 3 treatment periods afterwards are vital. And they're vital they're vital in establishing the alliance, of establishing your plan of care and the excellence of that plan of care. But really what in my mind is most vital is in establishing their role in that. Because if they're just receiving your care, then it's passive. And everything is just passive. I passively experience pain, and then I guard against it to try to stop it. And I passively receive advice and treatments and injections and medication and whatever. And through all that, no wonder they come in and feel like they're no longer themselves. They don't know what their identity is. They don't know their place as a person in pain. And they don't even know if they're going to ever be a person without pain. So when you can bring them right back center stage where they should be, it does wonderful things. And that's exactly it. You give them the opportunity to really try to figure out their own solution, and that has relevance and meaning, and it just changes everything. They go home happy, as they should. And those are the opportunities where you can then coach. So going back to like that original question, well, I'm not going to do anything different. In some ways, you probably will, but I might, just a little bit. I might still, stretch a muscle out. I might still give an exercise, those kind of the fundamental things that I think that I need to improve in mobility, motion, whatever, this and that, are probably the same. But the way I go about it at this stage of the game is got to be nothing like what I ever, would have studied beforehand.
And, sometimes you have patients that come in and they expect that sort of thing. So, when I was doing massage therapy and I was really into a little bit more outside my field, like I was into Sarman and all that, and putting people against the wall and muscle firing patterns and all that. So when I did away with all that stuff and the testing, and it was mostly more athletes, but they would come in and I just had this sense, okay, they're going to they want me to test their hip rotation but it didn't mean anything to me, but I felt like it would mean something to them. So I would go ahead and just do it anyway. And I could see their countenance change, like, okay, now let's, what you're doing. So I'm ready for, so those situations are kind of interesting.
Right. Yeah. I think that there are some times you can kind of educate them as to why I may or may not do something. And then there's sometimes, like you said, that they're expecting, my last therapist, would give me some heat after we were done. Okay.
Sometimes you have to give them a little bit of what they expect, because otherwise you shut them down.
Absolutely. And any test and any procedure and anything that you do is an assessment that should provide an answer to what do I do next. And so any test that you choose to do or not do should do that. And that goes back to like the reasoning model as well. Like any test that I perform, most of them are designed basically for that first level, what is the local factor, but it's not unimportant. So I'll still do tests like that to determine what do I think is happening. And then I can step back and say, what do I think is the interrelated type of movement variables that may be making this maladaptive versus adaptive, and why is this sensitive and why is this staying sensitive? So like in a lot of ways, I look at the problem now as now sounding like a jackass, but I think it was Michelangelo that talked about the David as saying he saw the angel in the rock and carved until it was set free. And I look at the patient the same way, and you've got to meet their expectations along with that. So while I'm trying to remove a barrier, change something so that the barriers to their function and movement can return, it's also a matter of what do they think is going to help them? Because that's part of that process too. And if I can't change their mind about it, or I don't think that's a battle worth fighting, okay, let's do it. And you know what? Trust the patient. Sometimes they know what's best.
And sometimes that opens up conversation, so if you're doing like this little test or whatever, they may just performing the test or the motion, they may give you some information that they may not have given you otherwise.
Yeah.
Not that you should go testing everybody, but just, it doesn't mean, like you said, throw the baby out with the bathwater. It still has a place in some sense.
Yeah. And I think that's exactly it. I think I probably, without even thinking about it, but I probably differentiate the idea of, okay, this patient has been led erroneously. They think they need a treatment that really doesn't work or isn't valuable, versus the patient request where, that's a good idea. Let's pursue that and see what happens. And either they're going to be right or they're going to be wrong. But either way, you get information from it. But there are certainly times where I've, they requested, Graston, and I don't ever do that. But okay, this has worked for you before and you got better. Okay, let's scrape something with a butter knife. I'm okay with that. Like, if that's what they feel that they need, and if they get better, then it's up to me to then, potentially move them in a different direction, or to explain why something else may have more value. But hey, we'll still do this. That's okay. Because they're there to receive value from your treatment. And if they already came assuming a value because they know that value, then I'm kind of, not being too smart by just poo-pooing the whole thing. So yeah, I think there's a time and place to trust your patient, to trust what they're saying is going to be relevant to them, but also to trust your instincts and to say, I think there's going to be a better way. Let's try them both, and you tell me what's better.
And so to touch on that, what does it look like if the patient, say they don't get to that point where they feel comfortable listening to you and they just want to keep getting grasped in every session, and nothing's really changing? How do you manage a patient like that?
I think that clear and distinct understanding of what your expectation is and what you think should occur is really important there. So it doesn't happen often, but there are going to be some points where you might say, okay, let's try this for 2 weeks. Within 2 weeks, we should be seeing change in these measures, how you're feeling, and the things you can do. And if not, then let's try something else. And they're usually very agreeable with that, because it's exactly right. They shouldn't just not be feeling any better if you've implemented something. And the same goes with my stuff too. So if I think that there's a treatment that should work and it doesn't, I'm not going to just keep doing it. I give it a week or two. And if I'm not seeing indication that, yep, this is a good idea, we're changing that. Otherwise, what's the point? Then I might as well just hand them off to some, to an assistant or something, and just, all right, hope you do well. I'll see you in a few months. So there should be that role of let's talk about it, and let's be about it, and let's see what happens. And sometimes it works and sometimes it doesn't, but that's okay, because if you've established those parameters, then we're all in agreement. And then ultimately that's the alliance, and they're going to trust you more when you trust them. And then they'll reciprocate that if you can, look at each other in the eyes and go, yeah, I guess this isn't really working. That's okay. We've got these other, methods. Let's try a few of those.
So what was it about the pain and movement reasoning model that hasn't been discussed so far, but that has really, got your gears rolling?
I think that it really was in some ways bringing everything back front and center. You learn a little bit here, you learn a little bit there, and no one's putting it together. And again, it's not the only paper that's done this. I just felt that this was a very good one in terms of how it just looked at all of these things in the same way that you would look at, I have this test and that test, and I put them together as a cluster. I look at it as a cluster of human presentation. And so for me, it became a very usable type of schematic to say, here's my collection of things here are my collection of things here, and these all interact the same way. And of course, that's O'Sullivan's cognitive functional therapy, and that's a lot of other type of approaches. So pick and choose. But I think that when you see these, similar lines of thought from clinicians trying to put things together, you find the one that makes the most sense to you. And for me, that the way that it was laid out made it very specific about how I could look for these things and how they can be interrelated. And that was joyous. It really is one of those papers that just go, okay, here it all is.
Yeah, because it's about the frameworks.
Yeah.
So here's the frameworks. So what are you going to add into this? And it seems like that could even change by the patient,
Yeah,
by who
absolutely.
comes in.
Yep, absolutely. Well, some patients are really high, on the central factors, and some patients really just, hey, I just tripped and hurt my knee. Okay, and you can have anything in between. And what I appreciate about it is when you're constantly thinking in those terms, not just here are my central factors and my local factors, but how they interact and how they go back and forth, and constantly, I don't want to sound silly, but it is like a three-dimensional chessboard versus traditional chess. You have to constantly be thinking on multiple levels. But when you do that, like you said before, or sometimes they say one thing and you go, oh, and then the same thing happens there. They say that one thing, and if you're thinking on all levels, you realize this is probably affecting that, and that why I can't get them to drop that resting tone, that guarding, that whatever. Oh my God, it's probably having to do with this, and I can work here to affect that. And that's really where it's at.
Cool. So we have to wrap up our time for today, unfortunately. But what is something that for the clinicians who are listening right now, who are going back to work Monday or going back to their break or whatever, what is something they can take from this discussion and use for their next patient?
Trust your patient, listen more, talk less, and be open to the possibilities that you're not exploring. If you do that, things are going to jump out at you that you just would have ignored in the past. And I think that that's a really important tool.
And just to speak on that, how would you open yourself up to things that you aren't expecting?
I think what happens is patients are going to express themselves. They're coming in, and that goes back to psychosocial, the idea that they are expressing their condition. And they express that through pain, they express that through changes of motor behavior, and they express that through a psychological, social interaction. So if you're looking for trying to find the barriers to their function, those barriers exist everywhere. And so if you're looking for those barriers, not focusing on, the detail of the biomechanics, and that's where we've gone for very long periods of time, but rather looking for what is a barrier? What is a barrier? Why can't they do this? If you can construct the why can't they function the way they did a month ago before this started happening, and you find those things, that's what allows you to open up and just to listen and to hear everything, because there may be relevance in the smallest comment.
So it sounds like you're saying, don't look for things that you think are the reason. Don't look for what you are assuming is the reason for the blockages. Look to let them tell you what those are.
Right. And to verify, to validate, to say, okay, I think this is what's going on, but I'm always walking in assuming I could be wrong about something. And again, if they're getting better and it's moving at a speed that you think is makes sense, you're probably less likely to pick up something that, that changes everything. But I want to know, what are my local, my regional, my central factors? I want to know that I've identified all of them. I want to know that nothing is missing. I want to know that I can make those connections and make it seem reasonable to me as a professional, as someone that, should be able to see those connections. And if there's something hanging out there that just doesn't seem to be connected to anything else, I want to know about that more, and I want to pick up on how can I make this fit? Does it fit? Does it have anything to do with anything? And how might that be affecting their movement, their behavior, the meaning behind just turning your neck, doing whatever it is that bothers them.
Cool. Well, thank you so much for your time today. And I really appreciate all this information. I'm sure listeners do as well. Feel free to rewind and listen again if you need to. But thank you so much for joining us today.
It was my pleasure. Thank you so much.